It is 12:30, and at this time I would like to call the November-December meeting of the Spokane Regional Health District Board of Health to order. We will begin with a roll call of members present, understanding at this time we do not have a quorum under which to take action, but we hope that that quorum will fill out as we go forward. So, Susan, can we begin with you?
Sure. Susan Boyson, appointed member.
Bob Lutz, Health Officer.
Tony Smith, Administrator.
Josh Kern, Spokane County.
Kevin Freeman, City of Millwood.
Karen Stratton, City of Spokane.
Michelle Fossum, Legal Counsel.
And Ms. Novel, Recording Secretary.
So, Mike, do we have public testimony or public comment today? So this evening we have, or this afternoon we have 8 folks. You state your name and address for the record. Your comments will be timed, and thank you very much. So the first speaker today is Jacqueline Gallagher.
Jacqueline Gallagher, City of Spokane Valley. I've prepared more than 3 minutes, which I know I'm only allowed, but you guys can please read through what I've put before you. Okay, so my name is Jacqueline Gallagher. To review why I'm here and have been here almost every meeting since February is that the Spokane Regional Health Department has not been transparent in their actions and communications with their board or the citizens of Spokane County. To recap, last December 22nd, 2016, Spokane Regional Health District was notified with a Dear Colleague letter from the Washington Department of Health that mumps was on its way and that most of the cases were occurring in Marshall Islanders, even though they are not exempt and less than 1/10% of the state population. Mumps got a foothold in Spokane over Thanksgiving break when Spokane and King County Marshallese celebrated the holidays together. There was widespread transmission during the Christmas break with parties, sleepovers, potlucks, and extended indoor close contact due to the frigid weather. The winter break exposure started incubating, and by late January and February, sorry, I'm nervous. Almost 30 schools and 4 districts had cases and were excluding exempt students. The pattern demonstrated it was not a result of an on-campus student-to-student transmission. Schools with high numbers of Marshallese had long outbreaks as mumps worked its way through the groups, schools, and low Marshallese numbers had short outbreaks. Because no exempt students were in the infectious chains, excluding them had no effect on the outbreak because virtually all infections was in the Marshallese, leaving them in school guaranteed continuing cases until they were all exposed and developed natural immunity. There were no exempt students contracting mumps on campus or off campus. If they did, they would have been allowed back with natural immunity. When parents informed the board of the fact about the outbreaks, you tried to help us, and that we are grateful, and thank you. You tried to bring some sanity to the situation. Parents, students, and concerned citizens have spoken at every board meeting since January, yet still have never been made an agenda item. After the urgency of getting our kids back in school settled, we consulted legal counsel, and we were surprised to be told that the exclusions weren't mandatory at all, after all. The county health officer has the authority to exclude, but to be mandatory, it must be implemented with the due process protections of the quarantine law. There is no statute that excuses the county health officer from following due process to make the exclusion mandatory. Spokane Regional Health District has yet to produce the statute. Most recently, board member Sam Wood requested the specific statute information, and he was given RCW 70-24, which was new to us. We thought perhaps our constitutional attorneys missed it. No, it has nothing to do with school exclusions. RCW 70-24 is titled Control and Treatment of Sexually Transmitted Diseases. There is nothing in the statute referring to school exclusions and relieving the county health officer of due process. Don't the citizens of Spokane County and Spokane Regional Health District Board deserve honest answers? Thank you.
Thank you. Next we have Christina Nielsen.
Hi, Dr. Christina Nielsen of Spokane City. When I was in school, I took an oath, and when I graduated, I took an oath. It was to protect the patient, do no harm, and to always stay up on the current research so I can best help my patient with current available, the most recent research. And there was, we learned about vaccines in school. It was mostly, this is what the vaccine is supposed to protect against, this is kind of what's in it, the dead, weakened virus. And this is the schedule. We didn't learn anything about VAERS, the Vaccine Adverse Event Reporting System. We didn't learn about the National Childhood Vaccine Injury Act of 1986. We didn't learn that the vaccine manufacturers were not held liable for any vaccine injury. We didn't learn about the vaccine inserts that are supposed to come with every vaccine from the manufacturer. These inserts are similar to a food nutrition label. They tell you some of the studies that the CDC has done for the vaccines. They tell you some of the side effects, some of the contraindications. I printed off just a few pages from one of the flu vaccine, the quadrivalent flu vaccine. This vaccine insert is 26 pages of everything that tells you about the vaccine. A couple of things I wanted to point out. This quadrivalent flu vaccine is recommended for 6-month-old children. Through 8 years, they get 2 doses of the flu vaccine, and then 9 years and older, they get one dose. Some of the contraindications, obviously if you've had a severe allergic reaction beforehand, if you're allergic to egg protein, things like that really at 6 months old you don't check the patient for. You're not checking for allergies, basically, if the child is going to have an allergic reaction. And that's really important to check beforehand. Some of the side effects, there's many: blood and lymphatic system disorders, gastrointestinal disorders, immune system disorders, infections and infestations, nervous system disorders, psychiatric disorders, and the list goes on and on. The flu vaccine, and this is just for the quadrivalent, but this goes for all flu vaccines and all other vaccines too. If you read every every vaccine, you can go to, I think it's immunize.org, and read all the vaccine inserts. That says there is insufficient data in pregnant women. So they don't know what can happen with pregnant women that hasn't been tested. It also says safety and effectiveness has not been tested in children younger than 6 months. Any of the studies that I found 6 months and older were either done by the CDC or the company itself. No outside research has been done on that. And the last thing, this quadrivalent flu vaccine has not been evaluated for carcinogenic, mutagenic potential, or male infertility in animals. Now you can find that exact sentence in every single vaccine. Thank you.
Next we have Kim Helm.
Hello, Kim Helm, City of Spokane Valley. Just continuing on a little bit from where Christina had, how she mentioned a little bit about pregnancy and the flu vaccine. I wanted to talk more about that. Why does the CDC claim a flu vaccine during pregnancy is safe and effective when even the H1N1 vaccine insert clearly states this is not true? According to all official health reports, we are now fully in flu season. It's that time of year when public health officials warn that everyone over 6 months of age and older should protect themselves and get vaccinated. This includes renewed propaganda to influence pregnant women to protect their unborn child. In 2013, Dr. Peter Doshi at MIT and Johns Hopkins University published a devastating report in the British Medical Journal discrediting the official fear tactics about flu season. In the report, Doshi stated the vaccine may be less beneficial and less safe than has been claimed, and the threat of influenza seems to be overstated. He notes that a study published by an Australian team found that 1 in every 110 children under the age of 5 had convulsions following vaccinations for H1N1. Separate independent studies conducted in the UK, Finland, and Sweden concur that the flu vaccine directly contributed to the rise in cases of narcolepsy following receipt of the pandemrix vaccine. The conclusion is that the vaccine triggered an immune reaction against the children's sleep center cells. If these serious events are occurring among children, what are the true adverse effects happening to an unborn developing fetus in the womb when the mother is vaccinated? The CDC's website states, if you are pregnant, a flu shot is your best protection against serious illness from the flu. A flu shot can protect pregnant women, their unborn babies, and even the baby after birth. Is there any scientific truth to this claim? We would expect that if this were true, then we would find this mentioned on the flu vaccine package inserts, but we don't. For example, for the H1N1 vaccine inserts, we find that it is not recommended in children under 6 months of age, and it is not known whether these vaccines can cause fetal harm when administered to pregnant women or can affect reproductive capacity. Why in the world would we give the very vaccine to a pregnant woman that is not recommended for a child who is under the age of 6 months? In 2012, the National Coalition of Organized Women received documents with statistics based upon the government's Vaccine Adverse Events Reporting System, VAERS, covering the 2009-2010 flu season. The CDC's own vaccine injury data collection revealed a 4,250% increase in fetal deaths after the flu shot. The VAERS statistics were confirmed later by Dr. Gary Goldman and published in the Human Environmental Toxicology Journal, showing that the H1N1 swine flu vaccine did in fact cause a 4,250% rise in spontaneous abortion, miscarriage. When confronted and queried about the rise in fetal deaths among vaccinated pregnant mothers, the CDC's Dr. Shimakaru confirmed the agency knew of this increase. So before you all get the next flu shot, take the advice listed on the package insert first and read the leaflet carefully.
Next, we have Paula Smith.
Hello, I'm Paula Smith, Green Acres, Washington. So an article came out not too long ago that revealed that 633 petitions for serious vaccine injury or death had been filed in the fiscal year of 2017. This is following 1,120 petitions that were filed in 2016. Keep in mind, at the time of the article, there was still 4 months left in the fiscal year. As several of us discussed in the October meeting, is that the number of vaccine injuries that are reported is about 1% per a study done by HHS. So we know that the number of petitions filed is just a tiny fraction of the total number of children who are seriously harmed by vaccine injuries, as doctors aggressively brainwash parents into believing their seizures, convulsions, and other serious conditions are never caused by vaccines and just a coincidence that happened to take place immediately or shortly after vaccination. Furthermore, families of vaccine-injured children must hire an attorney to file a petition with the U.S. government, then wait anywhere from 2 to 10 years for a decision by a court system that has everything stacked against them. Thus, in nearly all cases of vaccine injury, parents are convinced into either believing that vaccines had nothing to do with the injury or that trying to fight the government for compensation is a complete waste of time. At the time of the article, the U.S. government's Health Resources and Services Administration had released the running tally of just past halfway 2017 fiscal year for compensatable vaccine injuries. It was over $142 million. To date, the U.S. government has now paid out nearly $3.6 billion in vaccine injury compensation, absolutely shredding the lies which continue to claim that vaccines harm no one and that they are completely safe. According to the 2017 vaccine injury payouts, we are finding that the flu shot is by far the most dangerous vaccine and the most compensated one. Of the 332 cases that were compensated this year, 275 were due to injuries or death from the flu vaccine. It is clearly the most dangerous vaccine in the U.S., and yet it's sold in stores and can be routinely obtained as easily as over-the-counter medicines with no consultation with a physician. Articles have been coming out over the last week that the flu vaccine is only about 10% effective this year, but is still being pushed like it's the solution to keeping everyone safe. This definitely doesn't cover what is needed for the so-called herd immunity, and knowing that the flu vaccine is one of the most dangerous with adverse effects, how does it even make sense that it's being pushed so hard for a possibly 10% effectiveness? On top of considering all this, we also must consider, where is the money coming from to pay all these individuals and families for the injury that they may acquire for the 10% effectiveness? Does the 10% benefit really outweigh the cost of $3.6 billion? Thank you.
Thank you very much. Next, we have Kim Stadler.
My My name is Kim Stadler, and I am from the Spokane Valley. In Syracuse, there is currently a mumps outbreak. It has spread to 120 people, all of which are vaccinated. In 2006, a second dose of the chickenpox vaccine was recommended for school entry. Shortly after school began, the Arkansas Department of Health was notified of an outbreak in students. Vaccination information was available for 99% of the 880 children. 97% of the children had been vaccinated for the chickenpox. In this outbreak, there were 84 cases reported. In 2006, a total of 219 mumps cases had been reported in Iowa. 79% affected were vaccinated. From 1988 to 89, an outbreak involving 269 cases of mumps occurred in Douglas County, Kansas. 208 occurred in students. 97.6 received the mumps vaccination. In 1989, a measles outbreak infecting 1,363 people in the province of Quebec was attempted to be explained away as occurring because of incomplete vaccination coverage. However, upon further investigation, it was discovered that the vaccination coverage among the cases was at least 84.5%. Vaccination coverage for the total population was 99%. And last but not least, 2017's worst outbreak in the nation happened right here in Washington State with 151 cases of the mumps. Once again, the majority of the cases were amongst the fully vaccinated. Many of us in this room were negatively impacted by the exclusions of the outbreak. Today I brought my daughter Jerica with me. If you were here last time, you may recall me telling you a tiny bit of her story. Jerica is one of the many children that are now suffering with vaccine injuries. She is brain damaged for the rest of her life, as she sustained a major case of encephalitis immediately following the MMR vaccine. If you were here last time, you may also recall one doctor after another coming up to this podium, expressing sympathy for my daughter while at the same time telling me her life was worth throwing away. As her mother, there are not enough minutes I could spend up here to tell you her life was not worth throwing away. Furthermore, I had no idea I was signing her up to be a sacrificial lamb for the herd. And case after case, outbreak after outbreak, I can come to no other conclusion that I ignorantly marched my own flesh and blood into a doctor's office, and I sat idly by and watched her life destroyed. Within 5 seconds, everything she was and everything she ever could be was gone. Her entire life was stolen from her for vaccines that do not protect the very herd that she was sacrificed for. Thank you.
Thank you. Next we have Rosemarie.
Yes, I'm not privy to your list there, but is it possible that I could be put to the last and allow these others and their related concerns to go ahead?
We take people in order, Rosemarie, so please, thank you.
You want me to? My name is Rosemarie Waldron Larson. I've been a several decades resident of Spokane area. I currently live in Green Acres, Washington, and I've been attending these meetings since 1997, so I'm reasonably well informed about what goes on. Everything that you've heard so far and will quite possibly continue to hear from these individuals concerned relative to the fraud of vaccination is absolutely correct. You need to question more and do your own research rather than accept out of hand what is given you by the special interests, because they do have their own agenda. One thing that I would like to make you aware of is, could the seeming inaction and/or the lack of transparency that is of concern to the speakers that have been here so far telling you things. Could it be the rule of law having been replaced by the governance of policy? Because it used to be that under law, if there was a grievance within the public relative to a bad law having been passed, we could have that grievance addressed. But when you have individuals in government who are elected by the populace being conned into voting to exchange the rule of law for the governance of policy, then people like myself and these individuals don't have the unlimited pocketbooks that the special interests do to fight that and correct it in a court of law.
Thank you very much. Next we have Phyllis Hess.
Thank you. My name is Phyllis Hess, and I live in Spokane Valley. It's come to my attention that Spokane may be considering adding fluoride to its water. I wanted to share some of my thoughts. Some people say one thing, others say another. Controversy. A minority of professionals, which include dental and medical professionals, researchers, and health food proponents, oppose mass medication by water fluoridation. Water fluoridation has rarely resulted in overfluoridation, but I oppose taking the risk. We have only had 3 such outbreaks in the United States, but in the Alaska outbreak, 262 people became ill and 1 person died. I say where there is risk, we must have choice. I'm speaking today to oppose mass medication. Sodium fluoride is a component of most toothpaste. It's been used as the active ingredient in wood preservatives, fungicides, insecticides, and rat poison. In rats, it works by causing lesions in the stomach, eventually leading to the rat bleeding to death. If you want to use a fluoride toothpaste, that's your choice. If you add fluoride to my drinking water, I no longer have choice. The evidence as to whether fluoride prevents tooth decay is controversial, but dentists don't usually admit that to their patients. Sodium fluoride is a byproduct from the aluminum industry and from the fertilizer industry. It's classified as a poison and a hazardous waste. On the toothpaste tube, they recommend using a pea-size amount and then include this warning: keep out of reach of children under 6 years of age. If more than used for brushing is accidentally swallowed, get medical help or contact a poison control center right away. United States Air Force Major George Jordan testified before the UN American Activities Committee Congress in the 1950s that in his post as a USA-Soviet liaison officer, the Soviets openly admitted to using the fluoride in the water supplies in their concentration camps to make the prisoners stupid, docile, and subservient. Is that what we want for our population? There are some medications that have an opposite effect on children as it does on adults. When did ADHD become an issue? When did parents start giving their children fluoride? Some say that in Nazi Germany, one of the first things that the government did was to add fluoride to the water in the ghettos where the Jews lived. Some say that water fluoridation started in the death camps in World War II. It was to make the prisoners more docile. Some say that never happened, but then some say the Holocaust never happened either. In the Attica prison riots in the previous century, fluoride was added to the water to calm down the prisoners and make them more docile. What's the real reason that fluoride is being recommended? Where there is risk, we must have choice. If you want additional fluoride, pills are available. What are our choices if it's in our drinking and cooking water? A last word on financing. To install the equipment of this mass medication would cost over $1 million.
Thank you very much. Lastly, we have Linda Thompson.
I'm Linda Thompson. I'm from Spokane Valley, and I am with the Greater Spokane Substance Abuse Council. I'm just here to ask that the board really support the tobacco 21 age. We're looking at prevention and how we can help our young people make the choice not to use tobacco, not to buy cigarettes. We know that young people up to age 21 are the ones who are mostly the source for our teens getting tobacco. And with our Washington Drug for Youth program here in 24 chapters across the region with about 2,500 young people who are making the choice to be drug-free, we've talked a lot about tobacco use, a lot about marijuana use, vaping, that kind of thing that all kind of folds in together with starting with tobacco. So I was just here to ask you to really consider being a leader in our state with helping to raise that to 21. Thank you.
Thank you very much. That concludes our citizen input for today, and I'd like to thank all of our speakers for respecting our time limits and giving their input. So at this time, I'd like to move on to the chair report. However, I would like to note for the record that we've been joined by Lori Kinnear, Mary Cooney, Brian Beggs, and Karen Stratton, so the board does now have a quorum. Thank you all for coming this afternoon. A few items on the chair report. This is my last chair report, and I will be passing that off to someone else. I'd like to thank everyone here for their support for me being chair over the last year, and I have enjoyed this greatly. It was a wonderful experience, and it was I will miss it in some small respects. Some. A few notes. We'd like to note for the record that Councilmember Munch is no longer a Spokane Valley representative, and so we expect an appointment from the Valley. We'd also like to, when we remind Valley that they need to make that appointment, we'd like to remind them that we need 2 representatives from them. Mr. Wood has been absent more than not, I think, and so hopefully they will fill that out. We'd like to note also for Spokane County that Ms. Boysen's term as an appointed member ends on December 31st. The county actually has at this point 2 open positions. We need to refill the position vacated by Dr. Lutz, and so we have a 30-day period for the time of that, so anticipate there will be action from the county during that time. Thank you. On both of those positions, hopefully. And then tomorrow, for the board's note, we do have an administrative appeal hearing for tomorrow at 10:30 a.m. That is scheduled right now to go no more than 2 hours, correct? Correct. And so it could go less. We will have more information this afternoon, but we do need a quorum for that. So folks that have indicated that they will be present, we're really counting on you to be there. Lastly, since this is my last meeting, I'd like to take a minute just to make a quick statement on everything that we've had here, Chairman's prerogative. I'd like to just say that public health is a discipline that goes unnoticed. Often we see instances where public health is unaware of some of the most of the things that we do as a public health agency. If we're doing our job, that means that you shouldn't see the staff. You should not see what we're doing. We're keeping folks safe and protecting the public health. Occasionally, though, public health is at the heart of some issues in the community that people have strong feelings about. It's important to distinguish where and how those opinions relate to the actual responsibilities of this board. I'd like to reiterate what the board's role is and help distinguish areas where public input is paramount. Regarding public health, what are the best venues for people to share their thoughts and feel heard, especially when no specific action is being taken by this board? We want to ensure that we don't give our community the false impression that their testimony or feedback can influence certain instances or areas of the board's governance. Washington law that relates to what we do as a board is RCW 705-060, which is probably a lot of the issue that we have because we're driven by numbers and laws and regulations. Though I thought it might be helpful to read this excerpt, which states, "We enforce through the local health officer or administrative officer appointed under the appropriate Washington law, if any, the public health statutes of the states and rules promulgated by the State Board of Health and the Secretary of Health." So this board is responsible for enforcing state law. We as members of the community and as elected officials are pleased to hear comments from our citizens. But changes to the laws and rules that we act under must be made at the state level. It's important for citizens to understand this relationship as they petition or call for changes to the board's or health district's policies and procedures. There are certain things as the board that we do under law, that we are required to do under law. Changes that we operate under are best affected sometimes at the state level. For a number of folks that have come here and expressed their views, expressed their passion with respect to certain aspects of public health, we also need to consider that there are other venues that your concerns should also be taken to. We operate the way we are guided under state law. So that kind of fills out my tenure as chair. As I said, I appreciate everybody's support, and I have had a great experience being here, so thank you all very much. Now we will move on to item 5, the agency report, beginning with Mr. Smith.
Thank you. We'll begin with the health officer report.
Good afternoon. Today I'll give you some updates, community updates, and then also, as I've been doing the last couple of months, talk about some public health achievements. Not surprisingly, this is the cold and flu season, and so we are starting to see numbers pick up. As of currently, we've had 32 hospitalizations for influenza. We've had 1 death that occurred a couple of weeks ago in a gentleman with some other medical conditions. I'll just stay here. We are seeing a slight pickup in pertussis, otherwise known as whooping cough. We've had a small cluster of illnesses in the Deer Park area. The incident case was vaccinated. The subsequent cases have not been vaccinated. We had another child who came down with whooping cough in the valley, likewise unvaccinated. Just want to mention quickly about STDs, sexually transmitted diseases. This is of significant concern. We are seeing a significant rise in some of these. We can see a decrease in what's called chlamydia. We've actually seen a slight decrease over the past year, but of great significance, we've actually seen significant increases in both gonorrhea and syphilis. This slide just sort of gives you an indication of that uptick in syphilis. Right now, 29% of an increase from last year. What's even, for me, even of greatest concern about this is that we now have 4 cases of congenital syphilis of the 5 cases in the state. And congenital syphilis is something that unfortunately will give that child lifelong problems, both physical as well as neurocognitive. So again, the fact that we have this uptick in syphilis, and historically in the past we had seen an uptick in primarily the population of men who have sex with men. We're no longer seeing that increase as great. That's pretty much stayed steady. Now we're seeing an uptick in the heterosexual population. So this is of great concern for us for obvious reasons. And again, it's a statewide issue, but it's also of note in our community. Just a quick mention about the community outreach. Over the past couple of months, we've had a number of immunization clinics throughout the community. We've served over 1,100 individuals, and we've provided close to 1,700 different immunizations. A couple of weeks ago, I went to the WSALFO meeting, the Washington State Association of Local Public Health Officials meeting over in SeaTac, and it was a great opportunity for me to meet my colleagues across the state. We right now talk on a monthly basis, but we only really physically get together twice a year. So for me, it was a great opportunity to meet my colleagues and also to really talk about some of the issues that are relevant for us across the state. We had a combined meeting with the Department of Ecology, and as we are well aware of with respect to the issue in Airway Heights this past summer, the PFAS issue was of note, and currently what's happening is the DOH and DOE are working on a statewide approach to this issue, knowing that it hasn't necessarily gone away. Another topic of conversation was lead in water, specifically focusing on approaches in schools. We know that lead exists in a lot of old pipes. The question is, what do we do with it? And there's a lot of different opinions as to what are the appropriate lead levels in children. So right now, it's a voluntary approach for schools that are asking to be tested. I think many of us would like to see it a little bit more rigorous, but that's currently the practice across the state. The proposed changes to AIDS-related RCWs, specifically this dates back to legislation RCWs that first were enacted back in the 80s during the AIDS epidemic. Things have changed significantly. We are no longer seeing AIDS as a death sentence. It is oftentimes viewed upon as a chronic disease. And as such, given the fact that it's been historically treated in a very criminal fashion, the effort is really to decriminalize HIV. And so there's an ongoing process to try to really address the RCW in a much more reasonable fashion. And so this approaches AIDS and HIV at multiple levels. But again, understanding that it's really trying to reverse and or change significant changes in previous legislation that really has been considered outdated. The final thing we talked about was our use of the PMP, or prescribing medical practice database. So right now at the state, every opioid prescription is monitored by what's called the PMP, and so I can go in and access those data. Last year there was a piece of legislation that made those data available to health officers. I, as a clinician, could go in there and look at my own prescribing practices. Last year, this legislation, as I said, opened it up to health officers to have availability of that information. The question is, rhetorically, what do we do with it? And so there was some interest to actually have health officers not only be having access to that information, but then to act upon that, to identify those providers in their communities who may be outliers in prescribing opioids. That's problematic. It's problematic at many levels. It maybe puts us in a position that is outside the scope of practice for health officers, but it was nonetheless something that was being considered and discussed. In some communities across the state, opioid overdoses are actually a reportable condition. And as such, it would provide health officers in those situations to actually track potentially the data. So an individual is seen in the ED with an opioid overdose. You're able to track where that medication came from. You may then be able to determine that that provider who prescribed the medication has a pattern of overprescription. And that's how it's been utilized by some of my colleagues. Bottom line is it's very controversial, and there are other organizations across the state that really monitor prescribing practices of physicians. And so right now, it's not of significance for us locally, but of note, those data are available for us to be aware of. Two issues which I would suggest to you are probably high on our agenda over the next year are these. We've already had some conversations, some preliminary meetings, and I would expect as the months unfold over the next year for you to be consistently hearing more information about what we're doing in these areas. Turning page is going to 20th century health achievements. As mentioned here, control of infectious diseases. If you look at 1900, I mean, by far and away, the majority of people who died at that time died of infectious diseases. these are some of the means by which those deaths have been addressed. Science has given us a much better understanding of the causes of those diseases. Again, the use of antibiotics, penicillin that came out in the 1940s, it really revolutionized the treatment of infectious diseases, bacterial infectious diseases. The immunization programs, and again, monitoring surveillance, again, one of the core foundational elements of public health. Water treatment, food safety, decreased crowding in urban environments, so TB, okay, from just exposure to people with TB, cholera, pest control. So in 1977, smallpox was essentially what has been eliminated from the globe. Pretty amazing when you consider the efforts that have been put forth to make that happen. I watched a seminar about 2 months ago. There were 12 cases of polio right now worldwide. 12. To maintain that 12 and to actually drop the number, it's requiring 450 million immunizations to prevent polio from recurring. So it's a worldwide effort that Rotary is very much involved with, as well as the World Health Organization. So just some examples. Rotavirus. Rotavirus in 2000 was responsible for over 500,000 deaths in children under the age of 5. Right now, less than 200,000 children die of rotavirus-related diseases. The vaccine is 90% effective in preventing severe disease, about 70% effective in just preventing disease overall. HIB, Haemophilus influenza, major cause of meningitis. Back in 2000, an estimated 12,000 cases of meningitis across the country. 99% effective, the vaccine. We don't see Haemophilus influenza meningitis any longer. The pneumococcus, measles, 97%, diphtheria, 97% effectiveness of these vaccines. So again, we'll hear that vaccines are ineffective. I would argue that from a public health standpoint, vaccines have been, again, one of the success stories to prevent a lot of childhood illnesses as well as adult illnesses. Any questions?
Questions from the board? Thank you, Dr. Lutz.
Good afternoon. I would like to begin my comments today with recognition of an award that has been given to the Safe Routes to School program for SRHD for the Spokane and Coeur d'Alene area as the 2017 Project of the Year. This comes from an organization called WTS, which is dealing with women in transportation. The WTS stands for Women Transportation Seminar, which is what began this international group of women, and this was earned by our program this year. So congratulations to Health Promotion and in particular the Safe Routes to School program. We did have an opportunity on October 27th for Mark Springer and myself to attend directly and for Dr. Lutz to attend the superintendent's meeting out at East Valley to dialogue with all of the superintendents who attended that about the challenges that were faced in the mumps outbreak, to talk about the sharing of information back and forth, and to have them understand the responsibilities of the health officer and for them to share their perspectives on how they were working to serve their students. So that took place in late October. As Dr. Lutz mentioned, there was the Washington State Association of Local Public Health meeting, which was with the County Leaders Conference over at SeaTac. These are the priority areas that were dialogued about from the WASOLFO group. Foundational Public Health Services, as you well know, is something that we have been working on for a couple of years. And in this next legislative session, the intent is to continue to increase knowledge of elected officials about what those foundational public health services are, not necessarily to be doing an ask for funding in this legislative session. Other discussion was around local public health authority. Again, the kinds of things that Dr. Lutz was alluding to. WSALFO has as one of its primary efforts is the support of Tobacco 21. The interest in looking at food, code, and safety issues, as there are organizations online who are beginning to want to be able to allow people to prepare food for others that is not governed or controlled by public health. Clearly, the implications of passing the capital budget and the Model Toxic Control Act has impact on our Environmental Public Health Division. And as Dr. Lutz just identified, the opioid epidemic is one that we continue to focus on here. Fiscal sustainability for all local health jurisdictions in the state is an ongoing dialogue. As I have mentioned to you before, we have been fortunate enough to receive this grant from the Kresge Foundation to address health equity. We have received the funding from that grant, and it will be a major focus of the work that we do in 2018 in this agency to assure that all of us as staff understand how we can best work to achieve health equity in our community, and then we will begin to work with community members during that time. It is folded into the equity component into our strategic planning. We're coming to the end of our current strategic plan, and our Goal 4 group from the current plan is working to identify the strategies and priorities that this agency will have going forward. And this is just a sample of one of the flow sheets that's looking at the tasks that are being done now to identify those priorities. If any of you as board members wish to participate in that dialogue, we would welcome you to attend our meetings and simply let Ann know and we will get you engaged with that. We also, from a staff survey this last year, had feedback that there were two things that the staff really wanted to work on. One was teamwork, and the other was conflict resolution. And so we contracted with Rick Kramer, who had done work for us in the past, to come and work with our entire staff. He did a presentation at our all-staff meeting, and then he worked with individual groups throughout the agency to help us establish team norms and to emphasize how to maintain those norms as we go forward. So that work continues and is underway. Our Community Health Assessment Board, the CHAB, is working to gather information for a community-wide health assessment. And it is looking at the various areas of focus that you can see in association and concert with Priority Spokane. Each of these work groups will meet 2 to 3 times, and we have a number of citizens who can attend those work groups. And from each one of those will be priorities within those individual sectors. And then prior to April next year, all of these will come together to identify priorities for us to approach as a community. This is the work that was done when we identified increasing high school graduation rates as a priority in the last cycle that we had done. And if you recall, the Priority Spokane success was recognized by the Robert Wood Johnson Foundation, demonstrating Spokane as a community showing a culture of health. So this work is ongoing. It is being led by our data center. Yes?
So, I mean, is it just following along the Priority Spokane and you're bringing a public health aspect, or is Priority Spokane following along the CHAB, or is it a new thing? I mean, I'm unclear the distinction.
It is a coordinated effort. Clearly, the community is looking to Spokane Regional Health District Data Center as the knowledge experts, one of the main providers of data, along with the Community Indicators Initiative that Dr. Jones has from Eastern Washington University. But this also meets the requirements for Providence and Multicare to meet their community assessment that has to be done every 3 years. So it is a very broad collaborative effort. These are the focus areas that grew out of the prior Priority Spokane area. We will be introducing additional public health data that we have into this overall process.
And I guess my question, so Priority Spokane has been convening some of these subgroups. Is that, or is there something
They
else?
are, yes, they are of the same.
Okay, thanks.
I want to speak to you a little bit about what was the last point from the Wasalfo meeting, which looks at funding for local public health. And what this particular graph shows you is the black line is the Spokane Consumer Price Index, the cost of living increase from, on the left-hand side, 1998, when the motor vehicle excise tax was passed, to today. And so that is the growth in the cost of living for Spokane. The red line on this is the state funding that we have received as what was called backfill. And the backfill was at a time when the MVET passed, there were dollars that came to public health from both counties and cities. The legislature recognized when the MVET passed, they were going to take many dollars away from cities. And so in order to provide continuing support to public health, they created this backfill account. And we have received, other than the first year there after the MVET passed, a consistent amount of money from the state year after year as that backfill. It is now called Local Government Assistance, LGA. You'll see that in our budget. Our flat line there is $2,101,429. That's the amount we get. We do get other dollars from the state, but they are very specific to programs or categories that they have to be spent in. A similar graph looking at Spokane County. Again, the black line is the Consumer Price Index. The blue line shows what county funding has done for our general assessment year to year. And so if we use 1998 as that baseline, you can see through 2009, the county worked very diligently to try and keep us on that same cost basis as we were in 1998. However, from 2009 to 2010, the county's assessment to us dropped by $258,510. The following year, they actually increased slightly. We got almost $50,000 more that year than we had before, so we were up to $2,000,005. Over the next several years, we got the exact same amount from the county. The important thing to recognize is that the difference between the blue line and the black one continues to increase. So as costs were going up, which we have to bear, the amount of dollars we were able to get from the county stayed flat. In 2016, the county reduced our funding by $350,000. In 17, it was kept again level with 16. And the number that I show you for 18 is what we had asked the county to contribute to us this year for 18, though that differs from the report that was in the newspaper. We are waiting to get some clarity on what is the assessment and the amount that they are contributing to the tuberculosis program for definitive action there. But the very best case from a public health perspective is that since 2009, the county's contribution to us has been reduced by $712,000. If the number of $2 million that was in the paper is accurate, and that is inclusive of both our assessment and of the TB dollars, then you can add to this about another $170,000. So we'll be almost $900,000 behind from 2009. So I have been contacted by the media to ask, has this most recent reduction been impactful? The answer is yes. We are, however, very conservative in the way we have used our dollars. I give enormous credit to our managers, division directors, and Mike and his team to assure that we are expending public dollars appropriately and efficiently as possible. What I can tell you is it's getting very tight. So this is our mission, vision, and values, which are current. They are being modified as we go into the next strategic plan, but they will be very much the same as this. So with that, may I answer any questions?
Questions for Torney?
I had a question of your meeting with the superintendents.
Yes.
What kind of report out is there going to be in terms of what their commitments are to providing educational services to people who are excluded?
What we heard in the meeting is that they felt they had done an adequate job. It's different than what we've heard from parents here. We did not investigate that into the specifics. Certainly, that is a discussion that the schools need to have with superintendents, principals, and parents where there is a difference of opinion. Their interest with us was really much more around the disease issues and to what degree the health officers' orders needed to be regulated or taken into account.
Okay. And it's beyond today's agenda, but I'd like to pursue that because I think some of us on the board we're really glad that you answered their questions, obviously. But we have concerns about that as part of our public health responsibility to make sure that education is continuous even if people are excluded. So I'm just going to mark that for a future agenda on how we as a health district can move forward on that aspect of it.
And my belief is that they would certainly welcome an opportunity for any of you to attend one of their meetings and have some dialogue with them. They were very open.
Thanks.
So.
Other questions for Tony?
Thank you very much.
Thank you.
Mr. Chairman.
We will.
I've got to leave to go to another meeting. I just wanted to say thank you for your service and your calm demeanor always.
Thank you.
It's appreciated. And best of luck. Thank you.
Thank you very much. We'll have 6.
We'll have 6.
Yeah, I think we have 6. 1, 2, 3, 4, 5, 6. Yeah, so we're good. Thank you, Ms. Kinnear. We appreciate you coming.
So the next report will be from Linda Graham.
Sorry, could I take a personal privilege, Ms. Kinnear, before you leave? I don't know when it becomes official, but probably Ms. Kinnear is not going to be on the health district from the city. Yeah, so this is probably the last time. So I just wanted to thank you for your service myself.
Thank you, Lori.
Yeah.
Okay, Linda will wait for the resolution pieces.
Okay, so any other agency reports at this time?
Mike will take care of his piece during the budget.
All right, so thank you. So at this time, we shall move into the consent agenda consisting of the meeting minutes from October 26th and the October vouchers. Do I have a motion on the consent agenda at this time?
I move we approve the consent agenda.
Is there a second?
Second.
Moved and second in discussion on the consent agenda. Seeing none, all in favor?
Aye.
Consent agenda is passed. Thank you. This brings us to our action items for today, which we will begin with item 7A, the election of a chair for 2018. I think in your packets you've were provided the chair responsibilities and the selection guidance. Typically, I think that we appoint the current vice chair to our chair.
I was going to bring a motion to appoint Mr. Hafner to elevate himself from vice chair to chair. And I believe he consents to that.
Does it really matter? Do we have a second on that?
I'll second that.
Moved and seconded. Is there any discussion on the motion to appoint Mr. Hafner to chair for 2018? Seeing none, all in favor?
Aye.
Aye.
Aye. Any opposed? Mr. Hafner will be the chair for 2018. This is the board's, there's no public comment during this time. Next is the election of a vice chair under the same goals, with the understanding that the vice chair is it will become the chair at some point in the future. So at this time we are open to nominations for vice chair for the upcoming terms.
I was just going to say that the condition of Chuck going to vice chair earlier, I promised I'd be willing to serve as vice chair, but happy if anyone else wants to, but I'm willing to.
My apologies.
So at this point, we have Mr. Briggs has kindly nominated himself as chair. Do we have any other, or vice chair? Do we have anybody else who is interested as vice chair? Do we have a second on Mr. Briggs' nomination?
I'll second that.
So right now we have a nomination for Mr. Briggs and a second. Do we have any discussion? All in favor of Mr. Briggs being vice chair, say aye.
Aye.
Aye. So, good luck to you. Good luck to all of you. So that brings us to item number C, which is the Resolution 1708 adopting the 2018 Spokane Regional Health District budget presented by Mike Riley, our comptroller.
Hi, thank you. This is resolution number 17-08 for our authorizing a 2018 budget. And what we're really looking for when we come to the board for a budget is a expenditure authority. That's the main thing we're coming to look for. And so I want to give you a little history on expenditure authority here at the health district. If you look at sort of our past, moving back, even way back before 2014, for about 11 straight years, our budget and our actuals were at between $20 and $25 million. We sort of stayed in that general range of where we were at. As we moved into 2016, that was the first year our actuals came higher than the 25, which was within our budget for that year. So we actually went above that. 2017, we have raised our budget up to the 26, almost the $27 million range, and I think we're really going to hit that about this year. We'll be under it, so we won't exceed the budget, but we'll be under that amount for there. And as you see in 2018, we have a $30 million budget proposed before you. The main part of that is we've had some growth in programs. I mean, not only from staffing, but also from new grants coming in and also existing things. Some of the big things that have happened is our opioid treatment program has grown from, I believe we were at about 750 capacity up to 1,000, and we are slowly getting up to that 1,000 clients that we are seeing. We're somewhere in the 950s. So where our average this year might have been about 925 people, we're probably going to have clients on there next year, and our average will probably be at about 975. So we're going to be right back up at that level of opioid treatment raising. Another place we have is our infant toddler network, which is in conjunction with the school districts, where it's service to children birth to 3. There's the dollars amount passing through from the state superintendents down to the schools, which we provide for the schools to then get providers to do the service to these children. The rate keeps going up, plus the number of children on the program keeps raising. And so that program is growing by leaps and bounds, and then going and getting up there. And then we did get a new grant this last year. We've always had an HIV/AIDS grant in our facility, but there actually was an increase. We took over a local program that was being run by another provider that came in here. So we are slowly getting at full capacity as far as people and dollars and rolling. And we did go and present to our Budget and Finance Committee, which I want to thank very much. Our Budget and Finance Committee this year was Mr. Hafner, it was Councilmember Beggs, it was Mrs. Boyson who helped, Councilmember Stratton, and former Councilmember Munch was our Budget and Finance Committee that we sat down many times and went over and looked over the different numbers, and hopefully will give me some approval on this. So what I'm looking for is, with their help of talking about possibly the budget, is looking for an approval of our budget for 2018 at this amount.
Mr. Smith, do you have anything to add?
No, I would just love those representatives from the Budget and Finance Committee to speak your perspective.
So, do we wish to have discussion prior to looking for a motion, or does anybody from the Budget and Finance Committee want to make
I'll move that we approve the budget as presented.
Is there a second?
Second.
Moved and seconded. Discussion?
At the meetings I was at, we found it all in order and very responsibly put together. And again, just wanted to, for anyone in the audience, we've essentially obtained new funding sources in exchange for providing new services. That's the growth. It's not really a growth of particularly existing programs. It's because we're asked to do more and we've been given more funds. So I felt like it was put together very responsibly.
Any other comments? Seeing none, we have a motion and a second. All in favor of Resolution 1708 as presented, please say aye.
Aye.
Any opposed? Seeing none, motion 1708 is passed.
Thank you.
Thank you. So now we bring us to Resolution 1709, adopting a Board of Health legislative agenda for 2018 State of Washington legislative session.
Right. So you have seen this all several times. So I'm just going to kind of turn things over to you, and maybe Brian wants to lead some discussion amongst you, and see if we can get a motion and a vote.
Typically, this is the board's meeting, so at this time there is not public input.
Just to point out, you said this right legislatively, and you were going to pass something that's fighting against us legislatively. So, if you pass that.
So, Brian, do you want to follow Linda's lead, or?
So just, again, I'm chair of this committee, and we vetted this particular proposal and adjusted it, and we had diverse political voices on the committee. There's not much of a change over last year's legislative agenda in particular. Several things were passed last year and achieved, and we put in to the agenda, we put into 3 tiers. Tier 1 are issues of our highest priority of the board, and issues where we're actually asking staff to pursue them and work them. And then tier 2 are things that we propose that the district make a priority, but really play a supporting role with other stakeholders, and we wouldn't take the lead, but we would chime in. And so one of them is Tobacco 21, which we're going to be discussing a little bit. And then the third are issues that we're concerned about, but we're really not pushing one way or the other. We're just monitoring. So that's how it's divided up. So the last category of that third of just monitoring is the biggest. That's just several issues that affect us, whether or not we like them or not. And so this is what the committee came up with, again, with staff support. Again, for the most part, existing from last year. Probably just a few changes, but mostly subtractions, not additions. Is there a major addition? I'm not sure.
Yeah, the main additions are the specific issue around the homeless management information system under the homeless youth category, and then the inclusion of the tax on hazardous substances and the certification fees around lead-based paint.
Yeah, and the last 2 are on the monitoring, but the homeless management information system, that issue is, there were some privacy laws that were interfering with cities and counties and health district from keeping good data on youth homeless. And so we're asking the state to change the law so that we can collect data and better serve that population. So it's real, in some ways it's kind of a housekeeping thing, but it has been an obstacle to serving homeless youth, which seem to be on the rise, unfortunately. But the other 2 are just saying those are issues that we're monitoring. So really, it's really only one change, one addition to the supporting with resources.
Right. And the only other clarification is, while Category 3 is monitoring, it's also we will take action when it's felt that it's necessary to actually have an impact.
Yeah. So anyway, I would move for approval.
So we have a motion for approval. Do we have a second?
I'll second that.
So we are at the discussion phase. Do we have questions for Linda or Brian on the legislative agenda? Not seeing any from the board. Yes.
So clarification questions. So you've got the Tobacco 21 here, but then we're doing a separate resolution on that as well?
Yeah, so the reason that it's placed here is to say that we will we're asking our staff to use resources as requested by other stakeholders at the legislature to pass it. But one of those supporting mechanisms, independent of this, is that we're asking the board to consider a resolution in support of it as well. But this is just making it part of our agenda. The other thing is the actual formal resolution in support of
yeah, and that resolution calls on the legislature to actually take action on it, as well as calling on other entities in the community to do similar resolutions to ask the legislature to take action. And this is something that the partners across the state on Tobacco 21 are really seeking to do, is really show that local support to the state legislature.
So I would just clarify that the resolution we're considering later would be an implementation of the agenda, but this is just the agenda.
Any other questions? So we have a motion and a second at this time. In no further discussion, all in favor of Resolution 1709 as presented, say aye.
Aye.
Are there any opposed? Seeing none, the motion is passed. The resolution is passed.
Thank you.
Thank you.
I now know a lot of what I'm going to be doing in the coming months.
So that does bring us to Resolution 1710, a resolution calling on the state legislature to raise the minimum legal age for sales of tobacco from 18 to 21. Linda.
Thank you. So we've provided you with a lot of information about the public health rationale behind Tobacco 21 over the last few months. We've given you data, ethical analyses, some information on monetary costs. So today, I'm not going to take a lot of your time. I really just wanted to focus on one key aspect of why public health and our partners are really pushing for this initiative in the state. So despite the fact that our current age restriction is at age 18, 88% of smokers start before age 18. And most of these youth get their cigarettes from those who are between the ages of 18 and 21. In fact, 90% of those people who are buying cigarettes to give to minors are between 18 and 21 years old. And this is because youth are very likely to know somebody in that program. It's their older, or in that age group. It's their older siblings, it's their older schoolmates, it's older kids in the neighborhood. So in considering Tobacco 21, we're not just concerned about whether youth who are age 18 are mature enough or have the right to purchase cigarettes. Really, we're concerned about the younger children making that decision at ages when they're too young to understand the significance of that decision. They're too young to understand the power of nicotine addiction, and because they are so young, they're more susceptible to nicotine addiction. They're too young to understand the lifetime of health issues and potential for early death they may be signing up for. And at these younger ages, they're particularly susceptible to peer pressure, and they have less impulse control. So by raising the age from 18 to 21, we would make it more difficult for these children to get a hold of tobacco. You know, some people have said that the fact that youth are getting a hold of cigarettes means that there needs to be greater enforcement of the sales requirement. But the question of enforcement doesn't really make sense because these sales are legal. The sales to 18 to 21-year-olds are legal. So it's not a matter of fixing the enforcement. And I think many would agree that trying to prevent the exchange of cigarettes among youth social groups might present some challenges. So really, we see Tobacco 21 as a proven strategy to prevent those younger children from getting a hold of tobacco products and to keep them from accessing tobacco through their social networks. See, now I think the one thing we can all agree on for sure is that we want to protect the health of our youth. And we've made great progress over the last few years, last many years actually, of preventing and reducing the use of tobacco by youth. But it hasn't been enough. We still have a lot of children that are susceptible to nicotine addiction and smoking. So Tobacco 21 is really about taking another step forward in protecting the health of our youth and their futures. So with that, I will turn things over to Brian and the rest of the board for discussion and a vote on the resolution, if you please. And Bob and I are here if you have any particular questions on the rationale for this.
Thank you. So before we turn this over, does anybody have any questions for Linda or Bob or anyone on staff at this time?
What has the rate of smoking been like as far as the last decade or so?
Oh, of course you asked me a question when I don't have that one in front of me. Overall, things have been decreasing just over time. But I believe we're still around, Linda, data center numbers, I think we're still around like 15% of youth having at least tried in the last 30 days.
Okay.
And I will double check that number for you.
And you mean below 18, not
Yes.
19
Yes.
and 20 that this
Right.
would apply to?
Below 18.
Yeah.
Okay.
Yeah. Commissioner, if I can just a couple things. In the United States right now, it's estimated that 40 million people continue to smoke. Of youth, the latest data that we have, and again, these are going back to what's called the Youth Risk Behavior Survey. At that time, and this is looking at high school students, a third of high school students admitted to trying or smoking cigarettes within the last 30 days. 50% had used e-cigs, and within, I want to say about the same number, again, admitted to smoking on a regular basis, the 30%.
How many was on a regular basis?
30%.
Of that third who had tried, or 30 as a whole had smoke on a regular basis?
That's interesting. That's a kind of a good statistical question. Again, just reading the data, it said essentially 30% admitted to being, like, for example, the day that they were asked, they said they had smoked cigarettes.
Okay.
30%.
Okay. Had smoked.
Had smoked that day, yeah. So the YRBS is administered. And again, the questions were, how many of you have smoked within the last 30 days? It seems like a question that that I sort of understood as being asked was, how many of you have smoked today, the day that you are being administered the test? And about 30% admitted to smoking that day, if that makes sense.
Okay.
So 30 over the...
That's nationwide, you said?
So the YRBS, yeah, it's a nationwide survey. Schools choose to have their students participate in those surveys, but it is a nationwide survey.
Okay.
Yes.
Do we have any data for Washington State, or by any chance anything even local, Eastern Washington, or specific to Spokane County?
Yes, we do.
Okay.
The youth survey, we have a lot of tobacco questions on it. I just don't have any of those figures in my head right here. So.
Okay.
Yeah.
Well, and I'm checking through the resolution. I thought we had this in the resolution.
There
20%,
were certain statistics that were in here.
Yeah, 26% of high school sophomores vaping devices, which is actually higher. It's about twice as much as those who are smoking cigarettes. So.
Okay, but I didn't see anything about ongoing. I mean, is that somebody experimenting one time? Is that continued use? Is the continued use of the entire data pool, or just those who had tried it at least once? I mean, it's just wondering if you had any more data that we could drive down into, because overall, I mean, we've seen the use of cigarettes going down, and I know
Yes.
there have been spikes in vaping devices.
Right.
Because I know we discussed that last month. I know.
Yeah, and you got the
Vaping
follow-up
devices.
on that,
Yes.
correct?
Yeah.
Okay.
On the vaping, yes.
Yeah. Well, what we can tell you is that about a quarter, somewhere between a quarter and a third of high school students have said they've used in the last 30 days, and we can tell you that 88% of those who end up smoking start when they're below 18. So it's a good fraction of those children who even start experimenting that end up continuing to smoke.
Are there any states who have implemented a Tobacco 21?
Yes, that was in your packet, I
Yeah.
believe, last month.
And then what types of results have they seen since implementing?
What they're seeing is a significant change. It's been implemented at the local level in several communities, and it's been implemented statewide in several communities. I think the initiatives either at the state or local level, there's upwards of 200 of them. And what we are seeing is actual data that shows a decrease in the smoking of particularly the younger youth, and then also between 18 and 21.
Yeah, just to echo what Linda said, this was passed out maybe last month or 2 months ago, and at least at this time, 270 plus cities and counties in 18 states, states of Oregon, California, Maine, and New Jersey, complete, again, T21, and then, again, communities throughout a variety of states, Minnesota, Colorado, Kansas, Missouri, Arkansas, Illinois. So again, quite a few communities. And again, to echo what Linda said, the data are pretty impressive. I don't know statistics. I actually saw them yesterday, didn't write them down. But again, especially in the under 18 population, they're not smoking. And again, I think a lot of it, Josh, comes down to the fact that it's called social sourcing. I mean, the reality is that, we've cut off access to cigarettes from retailing primarily through, getting rid of vending machines. And again, by laws that prevent underage sales. But they source from their 18-year-old friends who are still in high school, their 19-year-old brothers. And so it's estimated that more than 2/3 of students under the age of 18 who access tobacco products get them from friends or family in that 18 to 20 age group.
Any other questions? Karen?
Dr. Lutz, I don't know if you can answer this or not. As I was going through this information and reading about vaping, are they saying now that vaping could be more dangerous than smoking a cigarette?
Oh, you are going down that. It's again, I think, we have decades of research on tobacco.
Right.
And you look at, over 4,000 different carcinogens in tobacco smoke. The challenges with vaping include, A, the fact that it hasn't been around long enough to really thoroughly study. B, the fact that because the e-juice is not regulated, the FDA can't necessarily say exactly what's in the juice. So you are pretty much, as a consumer, dependent upon what's written on the label.
If there is a label.
If there is a label. So there's those issues. It has not been shown, in contrast to some of the literature, to be a successful means to cease tobacco usage. The reality is that a significant percentage of people double use, and so you're actually oftentimes increasing the amount of nicotine that you're using. Two other things, if you look at the percentage, if you look at the amount of nicotine that are in these products, they call them nic, the amount of nic, so it's like a 24 nic. So something, I forget the numbers now, but again, there's a certain nic concentration that's equivalent to a pack of cigarettes. So if you are going in to buy because you want to decrease your tobacco usage and you said that you're a 2-pack-a-day smoker, then they'll give you a 24 nic juice to use, and that apparently is the same nicotine concentration as what you'd get from 2 packs of cigarettes a day. The sales of 0 nic e-juice is less than 1%, incredibly small. So the reality is that whereas they will tout the fact that these are products whereby you are A, decreasing your use of nicotine, and B, sometimes you are doing it just for social purposes and you can use 0 nicotine product, the reality is that nobody's buying 0 nicotine product. I guess the final piece for me is that if you look at where big tobacco is right now, they've purchased the majority of e-tobacco products and companies out there. Mm-hmm. So they realize that nicotine is an addictive substance. It's not the tobacco, it's the nicotine that's the addictive substance. They realize that, again, if you are introducing these products, and they target, I will be honest, I've gone into a couple of shops and it's, Tutti Frutti. You're not going to go buy Tutti Frutti. You're not going to buy bubblegum flavored or Fruit Loop flavored e-juice. But that's some of the flavors in there. So again, the research is suggesting that there is a very, very deliberate effort to target youth by the flavors that are being presented, and again, the fact that nicotine is the addictive substance. So you are essentially providing a youth who, again, the studies have consistently shown that youth are more likely to become addicted to any substance, let alone just nicotine. But you're essentially providing an addictive substance to a young person. And again, they're getting them from these older individuals. You can't sell them to youth, but unfortunately they're still using them. So you're providing an addictive substance, which then the concern is that it's going to transfer on to maybe using combustible cigarettes. Yeah. Long story.
Yeah.
No, thank you. That
Karen,
was
if I could just add a couple of things onto that. Thanks, Bob. Is that most of the youth are unaware that there's actually nicotine in these products?
Yes.
Because there's no good labeling. They've been sold as, oh, it's just vapor, they're harmless, they're tutti frutti. And the data is showing that kids are moving from vaping devices over to actually smoking. And also, just on the idea of the marketing and the tobacco companies, is the tobacco companies have been known to say, they have been quoted saying that Tobacco 21 changes would devastate their market going forward, because they would lose. They know that that's how they get the young kids hooked, and they know that how they're going to end up losing their lifelong customers is through Tobacco 21. So they're very worried about these bills.
Well, the interesting thing is after our last meeting, I chatted and kind of did some research, and I actually asked a few people who were vaping, and what I heard was it's safer. They think that it's safer than smoking, and I thought, I'm not sure that's right, but
yeah, I think a lot of people would argue maybe it's safer. The problem is we don't really know what's in there.
Exactly.
And people have been known to make their own vaping juice, so who knows what's in that. But are they safe? No.
Yeah. Thank you.
Any other questions for staff?
I was just going to note for the audience that we did get a handout that says high school students smoking are 7.9% in Washington, but vaping 18%, so about 26%. And nationally, high school smoking is 8% and vaping is 11.3%.
So at this time, do I have a motion on Resolution 1710 as presented?
I'll make a motion that we approve the resolution.
Is there a second?
Second.
Moved and seconded. Discussion.
I'll just, in general, I'm on the personal freedom spectrum of politics, but it seems like alcohol, marijuana, and tobacco are substances that under our human condition are subject to abuse and mind altering and sensitive to the lack of development and brain function in people until they get a little older. And so I think it makes sense to treat them all the same. And so, there's all sorts of great public health benefits. There's lots of taxpayer savings and healthcare costs avoided. So for all those reasons, I'm going to support it.
Any other discussion?
I'm right here.
Oh, Karen, sorry.
I was just going to say that I support everything that Brian has said. I struggled with this at the last meeting when we talked about it because my logic was they can vote, they can sign up for the military at 18, and I struggled with that. But after doing some research and having some conversations, I do think that I had to take this as a public health issue, looking at prevention, and also looking at the sales of alcohol, marijuana. It's all 21. So I have thought it through and will support this.
The other discussion. It's good.
I will, instead of repeating everything you just said, I will concur with what Councilwoman Stratton said. I have a 19-year-old son, so I'm struggling with this from that perspective as well, that he doesn't smoke. He's at college, he's on his own. I'm, truly for, not wanting government to impose other regulations on people. But also having seen the high school side of it, and seeing the kids smoking just off, the campus of the high school, and it's not just the 18-year-olds, the seniors, they're getting the younger kids to do that as well. That I think from a public perspective, I will be supporting it.
Any other comments? Seeing none, we have a motion and a second. All in favor of Resolution 1710 as presented, please say aye.
Aye.
Are there any opposed? Seeing none, the motion is passed unanimously.
Great. Thank you all very much.
Thank you very much. So that concludes our action items for today. Do we have an executive session?
We do not, sir.
We do not have an executive session, so board member check-in. Ms. Boysen. Ms. Cooney.
Nothing for me, thank you.
Mr. Kearns.
Nope.
Mr. Beggs.
Not today.
Ms. Stratton.
It's all about budgets for the city of Spokane right now. We'll be in better mood in a couple weeks.
So I would like to thank everyone, and we will set our next Board of Health meeting for December the 8th, so that will be the special meeting for the administrative hearing, and then at that time we will set our regular January meeting. So thank you all for coming. Do I have a motion for adjournment?
So moved.
Second?
Second.
Moved and seconded. All in favor?
Aye.
Meeting's adjourned. Thank you all.